All right, hi everybody. Welcome. I'm glad to see Amber here because we didn't see you in the waiting room. Big sigh of relief. We're going to give it a few minutes while people are coming in. We just opened the, I guess, the floodgates, as it were. Let's see. We still have people coming in. Yeah, still have people connecting to audio. So while people are connecting, I'm just gonna chat at you for about another minute or so, and then we'll go ahead and get started. So so if you are able to name yourself, I would go ahead and name yourself so that we all can see who you are. I understand on some phones that's not possible. And I did want to say, if you're on a telephone, I am not super Zoom savvy. Renee Nashtet is running the behind the scenes Zoominar today. So we don't believe, she's the Zoom bouncer. If you say anything inappropriate, she's bouncing you out. I had that one experience with the California long-term supports and services collaborative meeting where they had a Zoom bomber, and so ever since then I've been so afraid that that's going to happen. So Renee is our Zoom bouncer. But if you're calling in on the phone, you have some sort of a technological issue that you can't log into the computer but you have access, I want you to email your questions if you have questions that you want to add, because we're not unmuting people unless we call on them, just because there's a large number of people and we want to get through a lot of information. So Sarah Cheney from Choice in Aging is going to be letting Renee know about questions that come in. There's Sarah, she was waving. S. Cheney at Choice in Aging. I'm trying to talk and do this. choiceinaging.org. I just put that in the chat. So if you have questions and you're unable to communicate them through your phone and you can't use the chat function, you can email questions to Sarah Cheney during this meeting. So I do believe that we have 60 people on right now, and I'm just looking to make sure that I don't see a bunch of bubbles that show that people are still trying to connect to audio. There's only one that I see that's still trying to connect to audio. So I'm gonna go ahead and get started if you don't mind. I didn't see Sarah Steenhausen. Please tell me she's on here somewhere.
She's there.
Okay, all right, I'm glad. So welcome everybody. Thank you so much for coming today. My name is Debbie Toth, and I am with Choice in Aging. We are a nonprofit organization based in Contra Costa County, but we serve Contra Costa, Napa, Solano, and Sacramento counties. And the reason that we are hosting this meeting today is I have a number of colleagues and I have a number of team members at Choice in Aging who have a bunch of questions about this long-term care at home benefit. And frankly, I have a lot of questions about this long-term care at home benefit as well. And being on the Stakeholder Advisory Committee, I have access to a lot of information and a lot of people, and I still don't necessarily feel like I understand exactly what it is or why it exists. I have some thoughts and ideas about it, and I also have some grave concerns about it that I'm going to talk about in just a minute. But the point is, if I am in the thick of it and I don't know the answers and people are coming to me with questions, I can't be the only one to provide answers, and I'm probably not the best person to provide them anyway. And so my hope was to bring people together in a non-formal setting where we aren't given 10 minutes to ask this series of questions and not be able to respond and have an interactive dialogue. It really was an opportunity for providers and advocates and people in the state-based, legislative-based, administration-based world to get together. Mostly colleagues of mine who work in the same space as I do, which is Adult Day Healthcare or CBAS, the Multipurpose Senior Services or MSSP, California Community Transitions or CCT. All of the people that we serve in those programs also typically use IHSS services. So sort of this place and space for us to get together and have some learning and some discussion. And what's really important to me is that discussion piece that's going to happen. So the way that today is going to work, as I said, everybody's on mute. You're welcome to put your questions in the chat box. You're welcome to raise your hands, but we're going to go through a series of presentations first, and then we're going to open it up for question and answer and dialogue. So I'm going to finish talking at some point in the very near future. And after I finish talking, Sarah Steenhausen, from the SCAN Foundation, who is our policy goddess, is going to sort of lay the framework of what this is, where it came from, the structure, and give us sort of some grounding in the basics of what we know today. And then Amber Christ, Justice Warrior, is going to talk to us about who is it going to serve and what gaps is it going to fill. She's going to explore that sort of territory. After that, Nancy Volpert from Jewish Family Service in Los Angeles is going to talk to us about MSSP in the context of this, and Lydia is going to talk about Lydia Missaelides, who everybody knows, but she was our CADS executive director for, oh, I don't know, 3 decades, and she's now the executive director of the Alliance for Leadership and Education, and she's going to talk to us about the adult day healthcare aspect, as well as some sort of bigger overarching thinking about this benefit. And then we're going to open it up, and we're going to answer questions. We're going to have some dialogue. And then I'm hoping at the end of it, Lydia can bring us all home by summarizing what we've heard, what we know, and really what we can do to shape what this benefit looks like moving forward. Because I don't think any of us who are on this call are observers, just observers. I think we are interactors and we are advocates. And I think anything and everything we do, we learn and then we do something with it. So I think that's sort of the point of this. So welcome everybody. I want to thank you for your interest and your care and your concern. And I just want to say, as a provider of adult day healthcare, the Multipurpose Senior Services Program, and California Community Transitions, this benefit initially was incredibly alarming to me because it came out at a time where it was being sold as a replacement for adult day healthcare and the Multipurpose Senior Services Program, and it was being sold as exactly what the California Community Transitions Project does. You know, it came out as being decompression for skilled nursing facilities, and we've been doing that with CCT since 2008 in the state of California. So there's a lot of people up in arms with questions, with concerns, and I am super grateful to have the experts in the room to talk to us about it, and then for us to engage in question and answer. So Sarah Steenhausen, I cannot see you on my screen, but I have been told you're here. There you are, with the oak tree in the sky, and maybe it's an oak tree and I'm wrong, but I'm gonna mute myself. And Sarah's the only one of the presenters who actually has a PowerPoint presentation, and Renee is gonna pop that up on the screen for Sarah. So while Sarah's presenting, we're just gonna be able to see a limited screen with her PowerPoint presentation, and then we'll go back to regular view. So I'm gonna mute myself, and Sarah, without further ado, take her away.
Great. Well, thank you, Debbie. It's a real honor to be here today and to see so many faces, familiar faces, people that I've worked with, and that I know I have a lot to contribute to this discussion. So thank you. I'm going to be just providing, as Debbie said, a context and overview for this proposed long-term care at home benefit. And then, of course, the following speakers will provide some more in-depth analysis. So next slide, please. So I just wanted to start with a little bit of the background that Debbie was talking about. You know, we all are very familiar with the figures that the population that is most greatly impacted by COVID-19 are older adults, people with chronic conditions, as well as recent data that's come out from the federal level showing that dual eligibles, those eligible for Medicare and Medi-Cal, are overwhelmingly impacted by COVID-19. And particularly when you break it down by race and ethnicity, it's really highlighted the tremendous health disparities, not only in California, but in the country as a whole. We also know that in terms of settings, nursing homes and congregate living settings have been really tremendously impacted by COVID, with over 40% of the deaths occurring in nursing homes, in our state. And all the while all of this has been happening this spring, we know that there's also been tremendous challenges facing our state budget, leading to a $54 billion deficit. I just want to give that context because, as Debbie noted, when this was announced, this new proposed, and I want to say proposed benefit because it's not been implemented yet, it's still in the planning phases, we were facing all of these challenges. So there was a lot of questions about what it meant for the service delivery system, and that's, I think all of these questions are still being worked through, and so you're having this conversation at a perfect time when you all can impact the outcome. So next slide, please. So as Debbie noted, when the department released this proposal, they said that the initial purpose was to decompress the population in our skilled nursing facilities. Because as we know, as we discussed, there have been a high rate of deaths in skilled nursing facilities from COVID. The state indicated that they were looking at a way to avoid unnecessary institutional placement and to transition more people from hospital to home settings rather than having them have to go to nursing homes for rehabilitation. It's important to note that while the department initially proposed this program benefit around that concept, the concept has since evolved, and the department is now saying that even while the model of care was initially envisioned to address the need to decompress skilled nursing facilities in response to COVID, they believe in general that the benefit will provide a more holistic and coordinated bundled set of home and community-based and medical care services. And they indicated that they're intending to support home care for qualified Medi-Cal beneficiaries by allowing people to transfer from hospital or a skilled nursing facility to home, or by preventing the stay altogether. So now what I want to do is kind of get into the program framework and what's been proposed so that you all can do have the important discussion of whether or not the proposed concept really meets the intent of what they're trying to do. Next slide, please. So what I'm going to do now is I'm going to walk through at a very high level what we know today about the target population, the service framework, the provider requirements, how it's been presented and proposed under federal and state authorities, and what the timeline is. And again, this is going to be very high level with opportunity for discussion to follow. Next slide. So when you look at the target population, I will just preface this with, there's a lot of questions on who exactly would be eligible for this. In the department's design paper that I'm assuming most of you have seen, they indicate that the target population are the Medi-Cal beneficiaries who require either short-term skilled nursing care, long-term skilled nursing care, or low acuity skilled nursing care. They've indicated that these can be people who are residents of nursing homes who require this care, or it can be people transitioning from hospitals to home care settings who require this sort of skilled nursing care. They've also indicated that it could be people in the community that require that level of care but could be at risk of institutionalization. But one thing that I want to note is that it is a little bit confusing because they indicate that not all Medi-Cal beneficiaries who require long-term care services would be eligible for the benefit. Some may not have medical needs that meet the threshold for care, and others may have too high of medical needs or conditions that would not be meet the threshold for care. So it's difficult to know exactly who would fall into this category and what the crossover is of population need from medical care services to home and community-based. So we also have some questions about whether the dual eligible Medicare, Medi-Cal population would be eligible, and the department is still working through that, and Amber will talk more about that. Next slide. So what the way that the service framework would work in this proposed benefit is that for the eligible population, they would enroll in this program and they would receive an individual person-centered assessment. And I want to put a little asterisk to that because we don't know how that assessment would work with the host of other assessments for programs in the community and in the medical care system. So what we do know, what we've been told by the department, for example, for in-home supportive services, is that people would still receive their IHSS assessment through the county. It would not impact their IHSS assessment, but the provider is supposed to assess the individual for their range of needs. The provider is also supposed to provide the transition services if the resident lives in either a nursing home or is transitioning from a hospital. So as Debbie noted, it sounds very similar to the type of services that the California Community Transitions Program uses, where they transition people from institutional settings to the community. But we don't know a lot about what that would entail in terms of transition service, whether they have purchase of service budgets, whether they have flexibility to help with in the array of ways that the current community choices or community transition project provides. The third component of the service framework for this benefit would be care coordination. And the department has indicated that they want the care to be coordinated across both home and community-based services, behavioral health services, and medical care services. And that's where a lot of the questions come up, because that provider would need to have control over all of those range of services to be able to coordinate or provide the care themselves. And then the fourth component of the service framework are home and community-based services. This is where a lot of the question comes in of what exactly those services would be, because in the design paper, a lot of the description of the types of services that would be provided are more medical in nature. If you have the design paper, you can see that there's a lot of, it looks a lot like skilled therapeutic and home-based services, or home care-based services that would be provided. So still some question about what the home and community-based services that would be provided would be. I do want to note, under the concept of home and community-based services, that if for people who are already on a home and community-based services waiver, like the multi-purpose senior service program or the assisted living waiver or the home and community-based alternatives waiver, they would be not eligible for this benefit. So they wouldn't coordinate those services for enrollees. They would simply say that you're not eligible if you are in one of those programs. But theoretically, for all other home and community-based services, such as those provided through area agencies on aging and other programs, would have to be coordinated through this program. So I think we need to go a few slides ahead. One more slide. Okay, next slide, please. Great. So I talked a bit about what services would be provided and what the responsibility of the provider would be. Who can be providers? The Department of Healthcare Services has indicated that providers of this benefit would need to be qualified and apply for a new licensure category called a long-term care at home agency. So in a new licensure category, this would be overseen by the Department of Public Health. So the Department of Healthcare Services would do certification, Department of Public Health would do licensure. There's been a lot of questions about what the requirements would be for these agencies. We have heard that, been told by the department, that home health agencies and hospice agencies would be pre-qualified for this licensure category and would just need to add it on to their license. We will have opportunity to talk more about what this means for home and community-based providers such as CBAS, such as California Community Transitions, MSSP, and others who are very skilled and knowledgeable about working with this population, and it's not quite clear whether they would be meet the qualifications as they're outlined to be providers under this program. So essentially, your responsibility, if you are qualified as a long-term care at home agency, these agencies would be responsible for providing, arranging, or coordinating all of the medical care, home and community-based services as well that are provided or coordinated under this benefit. So again, if these are more home health entities or hospice agencies, there are questions as to whether they have the experience in the home and community-based sector to truly understand the needs of individuals and coordinate those services. Those are some of the questions that have been brought up that Lydia will talk about more, and Nancy as well. In terms of reimbursement, the state has indicated that the agency would receive a per diem or a monthly payment on a fee-for-service basis from the state. And in managed care arrangements for Medi-Cal managed care, that provider agency would contract with the Medicaid managed care health plan and receive a payment through the health plan. I think there's a lot of questions about what this means for managed long-term services and supports, for the movement towards more integrated service delivery system. Again, we're not really clear. It appears to be just an additional benefit that would be included in the contract for these managed care plans. But again, more information is needed in that area. And the state has also indicated that they would determine the services and the activities to be reimbursed under the contracts. So that leaves a lot of flexibility as it's currently defined. It's not really clear exactly what would be reimbursed under this proposed benefit. Next slide, please. I want to kind of focus on something that sounds really wonky, but that's really critical, because the reason it's critical about the federal authority that's been outlined for this new benefit, the state is proposing this benefit as what's called a Medi-Cal State Plan Amendment 1915I State Plan Amendment. Under a state plan amendment, the state is required to provide a service on a statewide basis, and it cannot establish a waiting list for that program. Why this is critical is because it provides a lot of opportunity for, we all are very familiar with the fact that many home and community-based services operate with long waiting lists. They're not necessarily available in all areas of the state. One very critical example of that is the community-based adult services program, which we know is not available in all areas of the state, and many people who could benefit from a service like that can't get it. So theoretically, for this proposed benefit, if it is part of the Medi-Cal state plan, anybody who meets the eligibility criteria for the benefit would be able to enroll in the benefit. I want to emphasize, though, that the department does have the ability to develop a very narrow criteria of qualification for the benefit. So it could be, just as an example, it could be that they develop a criteria for eligibility that's pretty narrow, so that only certain people would meet that. Maybe 600 people in the state, just as an example, would meet eligibility criteria for it. So essentially, it's a way of narrowing the program to a very specific population. This is why it's so important that we get a clear understanding of what the eligible population is for this benefit and who they're trying to target, particularly in relation to the state's dual eligible Medicare Medi-Cal population, of which there are 1.4 million dual eligible individuals who are among the highest need population in the state. If they're carved out, there's a lot of questions about who actually could receive this benefit. For the state authority, the department has indicated that they need new state legislation to establish this new licensure category for the long-term care at home agencies. But what's important to note there is that the legislature may very well be interested in playing a bigger role in terms of developing and overseeing the requirements under this new benefit. So the Long-Term Services and Support Subcommittee has been working to try and educate the legislature on some of the questions and considerations that they may want to raise with the state to determine whether they want to play a greater role in terms of statutory authority for this new proposed benefit. So next slide, please. So just to wrap up the timeline, I want to emphasize something really important. This still is a proposal. It is not a done deal by any stretch of the imagination. So right now the department is doing a lot of stakeholder outreach. There's the formal stakeholder process that they're convening through the Master Plan for Aging Long-Term Services and Support Subcommittee. Their next meeting for that is July 17th. But they're still holding other meetings with stakeholders through, they said through August. They're going to finish in August. Then in September, they're going to post publicly a draft of this state plan amendment that would outline all of the specifics of this benefit. And they allow a 30-day comment period so that they can take in the feedback from all the different stakeholders. And then in fall, they're seeking approval from the federal government, from the Centers for Medicare and Medicaid Services. And they have indicated that they are planning for implementation in early 2021. But there's been a lot of considerations raised about what this means for stakeholder engagement, wanting to have a very thoughtful process, how you ensure that the actual infrastructure can be established by early next year for something that's a whole new benefit. That means getting new providers on board, getting this licensure category established, and ensuring that we have the workforce and the services throughout the state to be able to launch this new benefit in 2021. And as we said, considerations about the legislature's role and just the readiness of the system to take it on. Another very important consideration is how to evaluate the success of this sort of a benefit and whether or not they might want to consider rolling it out on a phased-in basis so that it can be evaluated before it's expanded statewide. So I do want to also point out, just to close before it goes to Amber, is that all the amazing advocacy work that you all did to save both CBAS and MSSP is really, really important. And so it's important that even right now, if this goes through and if it is implemented in early 2021, at this time it will not impact CBAS or MSSP. That does not mean that separately advocacy won't be needed ongoing basis to ensure that CBAS and MSSP are protected in ongoing budget discussions, but for now this does not impact that. And I think it's been pretty clearly communicated that this sort of a benefit is certainly not a replacement for those programs, but the hope would be is that those programs could help build out a really successful long-term care at home benefit. Because if this were done the right way, the enrollees would have access to not only medical care services at the home, but also home and community-based services. And again, there is tremendous potential if this were done in a way that is in line with what people need at home and in the community to expand access to home and community-based services as part of an integrated service delivery system. So that's everything, high-level overview, and thank you for the opportunity to be here.
Thank you, Sarah. And I just want to remind everybody, the vast majority of Sarah's presentation was based on information that we know that has come out of the Department of Healthcare Services, not that Sarah made up. So there is a lot more.
Definitely didn't make this up. This is not mine.
Yes, this is not Sarah's. This is a summary of all the information that has come out of the Department of Healthcare Services as it relates to this proposed benefit. I will be very careful to say that. And I will just hope that I'm seeing a lot of really good questions being asked in the chat, and I'm going to ask the rest of us to speed up a little bit because I really do want to get to question and answer part. So Amber, where are the holes?
Hi Debbie, and thanks Sarah for such a great overview of the information we have so far. And quite honestly, all the questions we're seeing in the chat are questions we all have because there are simply not answers yet. I will reiterate that the long-term care benefit is supposed to be available both in managed care and fee-for-service for all Medi-Cal beneficiaries. It's supposed to be, they describe it as a new model of care with bundled services that are both medical and social. And this is key, that it's budget neutral. And by budget neutral, that means that whatever benefits being given, that the cost of giving such benefit are offset by savings of some sort. Ideally, those savings would be coming from the cost of nursing facility care, which is very high. So the idea of keeping individuals either from going to a nursing home after a hospital stay or from the community, or transitioning individuals out of the nursing facility into the community would offset the cost of this benefit. That's pretty critical, right? Because they're not going to spend any more money on these services. So for me, that means really, and I've seen these questions in the chat function, who is this benefit really targeted to and what gap is it filling? Because today we have a wide array of services available to individuals. We have IHSS, we have CBAS, we have MSSP, we have nursing homes, we have the California Community Transitions Program, which helps to transition individuals from the nursing facility into the community. We have palliative care benefit, we have home health, and then we have the array of Medicare benefits that the Medi-Cal benefit should wrap around. So we have all of those services. So what does this benefit, in my mind, what are we trying to accomplish with it? And for me, the largest gaps that we see for people, I think there are kind of three buckets of gaps that we see that prevent either somebody from going from the hospital to home if they're, instead of having to go to a nursing facility, or prevent people from going into a nursing facility from the community or transitioning out of a nursing facility into the community. So the largest gap I see, for example, when someone is transitioning out of the hospital after an acute care stay from going home instead of going to a nursing home, is that Medicare is usually the primary payer. And Medicare's home health benefit is pretty limited. It is not as robust as the kind of care you're going to get from Medicare payment and a nursing home. So what you really need is Medi-Cal home health and benefits to wrap around that Medicare benefit. And that's really hard to navigate right now. So what we see people having to do, because it's not well coordinated, as we often see for dual eligibles, is that individuals end up in a nursing facility, at least for the short term, to receive that care. And if the goal is to not have that happen, then what we'd ideally want is that this benefit would wrap around and coordinate to make sure that people could go home instead and get that complete kind of robust home health medical services they need, in addition to social services they need to remain in the community. But how can this benefit be doing that if it's budget neutral? Because all of those savings for that Medicare eligible individual will go to Medicare. That does not go to the state. So I don't see how this benefit can fill that gap if it's going to be budget neutral. So that's kind of the first gap I see. The second gap is about, if we're really just talking then about it serving people who, if we're going to talk about budget neutral and it's going to only serve individuals who have Medi-Cal only, that's a subset of people who are 65 and over, or who are going to need nursing facility level of care. Around 600,000 individuals fall into that bucket in California. A large number of them are in a waiver already, so would be ineligible for this. So again, not sure who the population is there and who they're trying to serve with this benefit. And honestly, most of those people are in Medi-Cal managed care already. So why do we need another licensing agency to come in to coordinate their care if in fact the Medi-Cal plan is already responsible for that? So again, not sure what gap we're filling there. And then of course, the other major gap we have is individuals who cannot transition out of a nursing facility or are in the community, and we're not diverting them from going into a nursing facility. And most of that could be helped if we had stronger, but that's not usually medical, right? That's usually social service supports. That's California Community Transitions needing to transition people into the community with all the supports that they need, and the biggest gap being housing. So for that group, this benefit doesn't seem to be addressing them at all, particularly because individuals who would be in MSSP or any other type of waiver are ineligible anyway. And then we're going to be licensing under this benefit a home health agency or hospice agency, which is predominantly a medical agency. And so they're going to be a medical model and not coordinating with the social services part of this. So why would we not instead be creating a benefit that's really bolstering the robustness of a California community transitions and focusing on how we can provide housing supports, because that's the major gap there. So that all leads me back to the major question of who is this serving and what gap are we trying to fill? And to date, I think I certainly have far more questions than I have answers. So, but I don't want to leave you with all that because I want to make sure that we're action oriented. So I think it's really critical, as Debbie said, none of us are people who just sit by and observe, that we stay engaged, that we call for a robust stakeholder process. If in fact, like we want more discussion, we want to create a benefit that's actually going to do something, then we want a robust stakeholder process. If this goes through the legislative process, we want, policy hearings and a lot of vetting to make sure that this is doing what it's supposed to be doing. And then we really want to ensure that this benefit, not only is it doing something, but it's not just adding complexity to the system, that we're not just having one more assessment for a narrow group of people, as Sarah said, that could be very narrowly construed. What we really want to be working towards, I think, as a state, particularly in light of COVID, is a way to provide care in the home to each individual who needs it, regardless of need and regardless of income. And is that getting us here? And I'm not, at this point, no, I don't think so. So those are my thoughts about the benefit, and I can turn it over, I think, to Nancy, who's gonna follow after me.
Thank you, Amber. I hope everybody heard that part about advocate, advocate, advocate. Okay, Nancy, take her away.
So first, thank you to Debbie for bringing us all together, and to all of you for being on this. There are 75 participants late in the afternoon before a, sort of holiday weekend, and I recognize many of you. I see many friends here. And I appreciate the opportunity to have this conversation. You keep hearing us say there are more questions than answers, and I think that's really true. And Debbie had asked me to talk a little bit from the Multi-Purpose Senior Services Program, which many of you are familiar with, but for those of you who aren't, just as a reminder, MSSP is a 1915C waiver program. Despite what the Finance Department has said in the last 3 weeks, we're not an optional benefit, we're a waiver program that provides intensive care management, social work services, nursing assessments, and purchase of services to frail low-income elders who are assessed as nursing home eligible. So that's the population. We have been a program for more than 40 years. We have had to prove to CMS every 5 years when our waiver has been renewed that we are a cost-saving program. And we, along with CBAS, and in partnership with IHSS, are the core of the nursing home diversion programs currently in place. And I think for us, among the many concerns, ditto to everything Amber and Sarah and Debbie have raised, and that I expect Lydia will continue to raise. But our concern is that in order to be cost neutral, and I see several questions about this, we believe that their expectation for cost neutrality relies on ultimately proposing again to eliminate CBAS and MSSP. And they said that in a budget hearing, and they said at the call last week, no, we didn't really mean it, but that's the only way you get there. And the other program that exists is the Assisted Living Waiver Program. And there are a lot of programs that are doing this. And if the question is access for people under 65, which is one of the questions, some of you will remember there used to be a program called Linkages that served the population of 21 and over that was eliminated in the 08-09 recession. And we'd love to see a way to build on the expertise and existing programs whether it's MSSP, CCT, the whole alphabet soup. And by the way, that also includes, I see friends from PACE on this call as well. And there are a variety of programs. And if the question is, we're not serving enough people, you know, from MSSP, we had a proposal last year to restore our funding and restore the additional 2,000 slots that are authorized by Medicare, but that by CMS, but that are not funded in the state. AL waiver, there have been legislative proposals the last 3 years to exponentially increase the slots. There's been requests to increase funding for CBAS. So there are a lot of questions for us about how about building on the expertise of the last many decades in the leadership of California, rather than trying to create something new. I want to echo something that Amber said about us really needing to advocate for a much, much more robust stakeholder process. This could be a very interesting benefit if we ever knew exactly what population it targeted, and then could be designed to meet those needs. But we think it should be built on the community expertise of the CBOs, like Choice and Aging, who have been doing these services, because, you know, we spend how much time talking about social determinants of health, and, you know, then meeting the whole needs of a whole person. And yet they're putting this in home health and hospice, two really important services, but they don't have expertise in the care management and in looking at social determinants. And so how do we anchor something like this to build on our existing expertise providing? So we're not the medical provider, but we work with home health, we work with Medi-Cal managed care, certainly in LA County. And the question is, how can we, instead of creating this new thing, find a way to take all of the expertise and wisdom that's on this Zoom and across the state to build something that will meet an actual identified need. And I think that's really where we are, and why we are looking to everybody to advocate, to submit comments, and to go back to our legislators and say, if we're gonna do this, let's do this right. You don't create a new benefit with 3 1.5-hour meetings over the space of 5 weeks.
Thank you, Nancy.
Right. So
that was like the most beautiful wrap of a bow, if I've ever heard one, on this conversation. And I thank you for bringing in all of that other flavor and context. And Lydia's up next, but I do want to say to folks, I am sorry, this is clearly going to go on a little longer than 4 o'clock. And I really hope that you can stay on, because I really do want to get to questions and answers. But I do think all of this context and the experts in the room for giving us information to help answer our questions and highlight those questions that aren't being answered is super important. So my apologies, we're running a little bit behind schedule, and I hope that you'll be able to stay on and continue this conversation for a little bit after 4 o'clock. Go ahead, Lydia. Thank you.
Well, my dear friends and colleagues have said a lot of really important words today, and much of what I was also reflecting on, but I wanted to note a couple of things. I've been scanning the questions as they've come in, fantastic questions. I hope you'll take those, everybody, and formulate some more and send them over to the Department of Health's website on this. I wanted to note the skepticism that's coming from the audience and also from my colleagues on this panel today. And I reflected back recently on the words of our director of the Department of Aging, Kim McCoy-Wade, who hosts the Master Plan for Aging's Stakeholder Advisory Committee, when they last met, and she talked about relationships being ruptured. And I feel like much of the skepticism that is coming from the community right now has to do with that. That feeling of distrust, the fact that this benefit came out and has been acknowledged to have started out as a COVID response, even though it still isn't clear to us what that response was going to look like, because this is still quite conceptual, and then morphed into a response to the May revision, which included severe cuts and elimination of programs that people with disabilities and our elders, who are the most vulnerable and needy around the state, require to stay safe at home. And I think those things combined warrant a great deal of skepticism, and this level of trust that was described, I think, is real, and I feel in my colleagues and in my the provider community that I'm very close to. And I think the other thing that was really remarkable that Nancy hit on, and Amber in particular, is that the concept, and it really has been just a very short concept until last week's multi-page paper came out, checked off most of the boxes for what CCT does, for what CBAS does today, especially in the Center Without Walls model that we quickly pivoted to. PACE, the LTSS programs that we all know and have known for many years are successful. It really did feel like a replacement, and some in my community believe that this was also a defensive move against a potential lawsuit that may have transpired in the event of elimination under the Americans with Disabilities Act. So I think the audience's questions and skepticism is well-grounded because of that history. And the way that I've been thinking about this is in a couple of ways. One, that this emerged as more of a political document than a well thought through policy document. Because Amber's asking the question, what is the problem you're trying to solve? It's still not been well articulated. We're eager to understand that, and for whom are we trying to solve that problem? So until those two things are articulated clearly and in a way that we all can understand and that is real to us, that we can relate to our communities, to the people we serve, to our families, I think that we do need to continue to ask those questions until we are satisfied. So I think I'm going to stop there. I was going to talk a little about the licensing piece, but I'm not going to. Others have raised that, and I would just note the fact that there are existing licensed providers like CBAS who could do this job with some additional flexibility. And if there is an urgency to this, and that is demonstrated to the community through further discussions, then it seems to me we could more quickly move to address the yet unidentified problem by taking existing providers, existing programs, and providing additional flexibility, additional funding. We could move forward much more quickly in a coordinated way. So that's all I'll say right now, because I know we're short on time, Deb, but thank you for this opportunity, and thank you all for being here. It's great to see many of my friends on this call today.
Sorry, I was waiting for permission from Renee to be unmuted. So the fun part about being like, actually it was nice not to have a lot of background noise. I have to apologize to everybody because I know it's not everybody's preferred method to be muted. I know that my husband would love to mute me, but it doesn't happen that way. But I was on a conference call this morning, and people just were unmuted and were making coffee and flushing toilets and like, ah! So I'm sorry for the muting, but it's really hard for people to present and talk when there's so much noise going on. So given the number of people, we chose this platform. So now I'm going to ask Renee to go ahead. She's been monitoring the chat and looking for hands raised. And I'm going to ask Renee to go ahead and call on people and unmute them so that they can have their question, put their question out there and frame it, and then say who they would like to respond to it. So Renee,
all right,
yourself.
Great. So thanks everybody for these amazing questions and the amazing conversation going on in the chat. One of the first folks to speak up was Jessica Lehman. I wanted to see if you wanted an opportunity to pose your question to the group. Not putting you on the spot and not putting you on the spot.
She's okay. She could be put on the spot. Did you unmute her?
Yes. Now it's unmuted.
All right.
Thank you. I'm fine being put on the spot, although of course I'm trying to remember what my original question was. But I started making myself a list of questions.
Go.
Sorry.
Let it all out.
I mean, a lot of these have been addressed, and you all saw in my chat my feelings about this. And I appreciate the honesty from everyone, but whoever said it sounds like this is only cost neutral if ultimately you get rid of CBAS and MSSP, which is a problem. I mean, I'm really wondering how this is different from CCT, and if this is more about the state trying to look good, that they're doing something about people dying in nursing homes, instead of looking at why do people actually go into nursing homes and what does it take to get people out. And, you know, and somebody said housing, right? That was another of my big questions, is like, we know specifically in the Bay Area, but all over the state, that like people can't get out because there's nowhere to go. And so if you don't do that, what good does it do to have a home health agency connected? So those aren't really questions, those are complaints. But I guess my one specific question, which sounds like a complaint but is not rhetorical, is there actually another complaint I want to share is like, we're only talking about nursing homes and we're not talking about all the other care facilities, which also feels like in line with the news that the public outrage has been about nursing homes, but we know thousands of people are dying in other facilities. So my question is, does the program actually have to happen at this point? Or like, is it mandated in some way, or could it actually be scrapped? And could we push to say, what is the actual problem we're trying to solve? And let's figure out the best way to do that.
Amber, I'm feeling like that's a question you can answer.
And thank you to this group for letting me be so brutally honest.
I love that. And I think I should clarify before Amber answers your non-rhetorical question at the end there. I should have said, it's not just for questions, it's for comments, it's for feedback, it's for advocates, providers, utilizers of services to have a forum that's not strictly mandated by the state in what we talk about and how we talk about it. So if you have something you want to say, raise your hand or put it in chat. Thank you, Jessica, for letting me put you on the spot like that. So Amber?
Yeah, so no, it could be scrapped. I mean, technically. There's nothing stopping that. I am a little concerned that they could do a gut and amend to a piece of legislation and try to get it into the session and into law, which I think will be a lot harder to undo. So I think it will require our advocacy to ensure that whatever moves forward, and if it's not this, that it's something that's actually productive. Honestly, like if looking at what's happening in COVID right now, my personal justice, and I would say this could be justice and aging too, but we should be looking at responses that are about using existing programs to transition and ensure people aren't going into residential congregate settings. That is not a safe place to be. So what can we do right now to build up to make sure that that doesn't happen? And that can be very quick things. Though they don't have to be some long-term care benefit at home. There are tons of flexibilities right now and a lot of ways you could invest resources in existing programs to make that happen. And to me, that seems like the most responsive thing to COVID-19 and the crisis we're facing right now. You know, ideally, we see this moment as a time too to transform our long-term care system and really think about making sure that any person can receive care at home, and that the forced choice isn't a nursing facility or other congregate setting. But in the very short term, the investments we think should be happening isn't more money into nursing homes, other than providing, you know, PPE and make sure people are safe there now, but using those investments, and part of the safety measures is actually helping transition people out. And there's a lot of ways we can do that, and a lot of time and resources is going into this benefit that could be going there. So I think, yeah, Jessica, we agree.
And Jessica, I'm sorry, Nancy pointed out in the chat, can you tell everybody who you are and where you're from?
Sorry, Jessica Lehman with Senior and Disability Action, and part of facilitator of the California Care Rationing Coalition.
Yeah, and the Care Rationing Coalition had 2 recent victories with the surge protocols now not going to kill you if you are older or you have a disability or you have dementia, and the immunity issue. So I think Jessica is a local legend here in the Bay Area, and a friend, and just a super human being. So thank you, Nancy, for asking, and thank you for my cat for now chiming in because he was way overdue for yelling at me today. So I do want to get to some more questions, comments, and feedback. Renee?
Yes, it looks like we have some people jumping on and off. So I tried not to attack everybody like I did poor Jessica, and ask them before I call on them. But unfortunately, you're going to be under attack. I'm sorry, guys. I don't have enough time to text you all. It looks like Bonnie Burns, you had some great insights about Medicare. I don't know if you wanted to ask any questions. And let's see.
Bonnie, you're unmuted. Go ahead, Bonnie. Oh, now you're muted. You need to unmute her again.
She's unmuted on my end.
Okay, Bonnie, on your end, you got to unmute. There you go. You're good.
Well, no, I didn't have a question. I listened to this in the context of having dealt with long-term care insurance. And there's no way in the world that you're going to have a cost-effective home care benefit long-term for people who need skilled care. That's just not going to happen. You know, you can look at Medicare and see how, you know, they do cover nursing home stays when there's a requirement for skilled care, but they don't cover it for longer than about 18 days because the need for skilled care goes away. They're not addressing the issue that would keep people out of nursing homes, and that's the supportive services. You know, so I don't understand what they're trying to solve, who's behind this whole idea, because obviously they don't know much about the services that are already available in our state.
Thank you. I don't, yeah, I mean, I think that your comments were spot on. And I think that, I think, and Sarah can correct me if I'm wrong, but I think the way that we were reading it, it didn't sound like the dual eligibles, they couldn't score savings from Medicare. So it's not clear how they would be able to make it a cost neutral benefit if they included those dual eligibles. So I don't know how Medicare and Medi-Cal play together in this. Sarah, can you help? You're okay. We need you to be unmuted. Renee, can you unmute Sarah?
So sorry.
No, that's okay.
Oh my goodness. A little too much multitasking here.
Okay, got it.
There we
Thank
go.
you.
Oh, now you're muted.
I think that two things. One, there could, for the duals population, technically, you know, for transitions from nursing home to home for the long-term stays, that would save Medi-Cal money, and that could be considered cost neutral. But for the vast, you know, for the people who are transitioning from acute care stays from hospital to home, or from people who are short-term Medicare residents of SNFs for rehab purposes and are transitioning home, that all would go to savings under Medicare. So you're right, Deb. And Amber had said this too. It's hard to figure out how this could be cost neutral to the state. It doesn't have to be cost neutral by definition of 1915I waiver standards, state plan amendment standards. The feds say that the state is allowed to do this in a way that's not, doesn't meet the same requirements for cost, you know, the cap that has to be achieved for the 1915C waivers. They can do this and actually spend resources on it.
But the state is saying they're not, right?
But Sarah, didn't we hear at one of the presentations that Department of Health said that was Department of Finance's add to the
It's the Department of Finance. It's
requirement.
Not the federal government. It's
right.
The Department of Finance. And the Department of Finance views home and community-based services as a cost to the state, because even if the person is eligible for institutionalization, so that's why people who are on the wait list for the assisted living waiver or for MSSP or for other home and community-based service waivers who live in the community, the state sees them as a net cost. If you're transitioning from a nursing home to the community, they see that as a savings because what they're paying for them in a nursing home is less than what they would pay for them in the community. It's kind of, it's not a very, I mean, these people in the community have been assessed as needing a nursing home level of care. So I think there's a big issue in how the state is defining cost neutrality, and that's really, that's going to be the big nut to crack in a lot of this in terms of expanding access to home and community-based services writ large until that issue is resolved. Because other states have done it. Other states have, you know, pushed forward in that
And
area.
Deb, I wanted to just add one thing to what Sarah is saying. I just thought of this actually because I've been reflecting on CCI and CalMedi Connect and kind of lessons learned there. But just as the state this year in the budget crisis, which I'm sure we're going to be in for the next few years, proposed to eliminate a whole bunch of optional benefits. And now we're going to tinker with CCI and move to something called CalAIM in the next 18 months or so. They could just as easily put up this benefit and then also take it down. And they could, if they're applying the cost neutrality argument from Department of Finance, could also discover that it isn't cost neutral and again, bring this benefit down. In the meantime, if they've eliminated a number of services or cut them back to a shadow of their former selves, we won't have anything to fall back on in the event that happens.
Yeah, we need to be super careful. I think goes back to what Nancy was saying in terms of like, we have this infrastructure. Our starting point needs to be building that infrastructure and creating that coordination within that infrastructure and standing it up, not making opportunities to lose things. Like we have to be really clear in our messaging and in our advocacy and in our questioning of why and how. So asking the question about where this started and why it started, and if you look at the messaging from where it started to where it went during elimination to where it is now, where they've taken decompression out of it, like there's this whole evolution happening, and we need to be smart and informed advocates about why, what's the impetus. And I think we go back to Amber's question, who are you serving and what gap are you filling? I think all of these things are super important. So I want to ask, because a lot of people put things in chat and I think a lot of stuff got answered and discussed in chat. If there's anybody who feels like they didn't ask a question or make a comment that they want to, if you're able to raise your hand like this, or you, okay, so I know your name is not, oh, well, I shouldn't say
It's
I
almost.
don't believe your name is not.
It is almost.
Almost. Okay, so Renee, can you unmute Marilyn Fried, who is really Amos? Yes?
It's where is
Marilyn Fried is what you're looking for.
okay, and just also let you know, I unmuted Captain Cooper Puckett on the line, so she does have an open line. Let's see here.
Marilyn.
Marilyn, not
Marilyn Fried.
There we go.
All right, so now you should have something on your screen so you can click on it and unmute yourself. No.
Almost, you're still muted, but you should be able to click the microphone on your screen, almost, and unmute yourself now.
You're still muted on the screen.
Hey, can we unmute it for him?
I did it on my end, but I think he's muted on his end. That's the problem.
Oh, there we go. All right.
There's
Hi.
Marilyn.
Hi, Marilyn. Can you press the unmute?
These are Los Angeles aging advocates, I just have to point out.
There we go. All
Southern
right.
California.
All right. Talk to us.
I've been sitting here and listening to all of you, and I appreciate your knowledge and your effort over the years. Some of you I know, some of you I don't. One of the things that struck me when I got the idea about this Zoom meeting from CSL, I was looking, and what caught me is stay at home. You know, here we are, I'm a senior, I'm 2 years old, and I'm at home because of what happened out already 19. One of the things that I believe that it should be for all of us is, I mean, when you go through a health issue and you are, what do you call it, you are a senior, most of the time when I was working in the field, I'm still working because I'm a member of a multi-purpose center, serving as the president of the council. But what it is we would like to stay home, period. Has nothing to do with medical per se, okay? I don't know why, based on what I've heard today, is there is a lot of programs out there which are addressing part of the issue. Why can't we just work together and basically, what do you call it, address of home, you know, when we are basically having problems, is that we really want to stay home. We don't want to go to a strange place. And I think that we need to start listening to the people that we are talking about it. There is no doubt each one of you is really caring. Each one of you have invested time and years, you know, to do what's necessary. But at the same time, there is too many programs all over. And I think that most of the seniors, you know, would not know or understand what is this all about. But they know one thing: when I get sick, I want to stay home. Don't send me anywhere else. And I think this is not what the message needs. If we want to get support from the community, that we need to start saying, we are going to have a program, a benefit for everybody, not just, you know, the people of medical. I worked with everybody in this Medicare, medical, Medi-Medi. It is not working in terms of making your last year life, you know, a little bit more, what you call, where you can really feel, it's okay, I know my time is up, but I'd like to be able to remain in my environment, my home, or my stay, you know, my children. You know, it's more than just the technology and you know, I have a heart problem, I have to admit. Okay, I'm not as involved as you are, and I thank you for it. I'm just a member of the CSL, and I've been working with legislators. And when it comes down to seniors, they say yes, yes. But when it comes down to make a decision or support, you know, it never goes. I'm real individually, not as a professional, okay? As individually, I'm very, very, what do you call it? I really feel bad for all the people. It has nothing to do with me personally. Right now, I'm okay, thanks God. But if you look at the whole system from the beginning to the end, what happened in the CNFs is really, in my opinion, it's a tragedy, but at the same time, it's a very bad comment about us. How did we allow this to happen?
Yeah.
And you have all the rules and you have the certification, whatever it is. This does not necessarily always gives a, what do you call, I don't feel comfortable, okay? And I'm only speaking for seniors, which I am working every day, okay? Because people call me and try to navigate. The navigation it's so complicated.
Yeah.
You know, and I worked with people with medical, you know, I work in a private company, you know, I had, you know, in hospitals. I mean, people just don't know, what do you want me to do? I mean, well, you are saying you have the resource, I'm coming to you and you still cannot really help. You know,
Yeah.
it's really not fair. And I hope I'm not as articulate as you people are. No, I'm really serious about it. And I am really representing seniors who are not articulated, but they have heart. They know exactly what they want. We don't talk to them. We don't talk to them. I understand that we serve them. They come in, sign the papers. I'll tell you what the policy is. That's not really knowing the person. This is what I think that as a professional, I'm a social worker. I've been working for 40 years in the field. And yet, I mean, we are still the same way. Nothing has changed. And you need to look at yourself if really you saw a lot of changes. Yeah, there is shift here and there. We got a little bit more money, whatever, but it's really not in terms of the seniors that you all know about, maybe a part of your family, maybe a friend, a neighbor. I mean, it is really, you know, if I ever thought that there is an opportunity, we did not take it a long time ago. And all this medical and Medicare and having to meet criteria. What do you mean meeting criteria? I'm a senior. I have a problem. I mean, how do you address me and you say, well, if you have this or you have this or you have this, you're okay. If you don't have it, I'm sorry. And that's what the issue is.
Thank you. You know, you're saying exactly, I think, if I can paraphrase, that everybody should have the right to age where they choose with dignity. And I think, yeah, and I think we've failed at figuring out how to do that thus far. And
so let's get together and do it together and not go talk about MSP and all the other stuff that we have. You know, this is all what's necessary. We all believe in it.
yeah, and
If I can jump in, I think, first of all, thank you, Amos. It's nice to see you.
Same here.
But I also want to add a thanks to Lydia and Sarah in particular, who are both on the Master Plan on Aging, Long-Term Supports and Services work group that really put a ton of work, months of work, into putting together a really thoughtful analysis and recommendations about how we could thoughtfully move forward in a way that is respectful of our elders and more comprehensive and thoughtfully. And so my other piece on this is, in any way that, in addition to advocating to try and avoid a gut and amend on this, but that we can always turn back to if people want a roadmap. We're unbelievably lucky. The timing is such that there is a draft of some things that we should consider. And I would add that as well, because I think we, on this call, have heard the voices, and we, you know, we fundamentally believe in the nothing about us without us philosophy. And so now it's a question of how do we take those who make the decisions and help them reframe it.
yeah.
Well, no, I just wanted, you know, I had attended another Zoom meeting, and one of the things was missing there. Everybody was talking, generally said, and I said, you know something, maybe as seniors or elders, maybe we should come up and join the, you know, the recent protest, you know, on the Black community, and say senior life matters too. All life matters, and not just one particular section. if we need it, let's bring everybody up to Sacramento, you know, with the knowledge that we have. It's already that you guys, you know, have been developing over the years with some very good, great ideas, but we need to implement it. And that's what I think. I received calls from people that know me, says, listen, how do I get some food? Which is, and then lucky, we had resources. You tell the person, call this number and you get. And that was some dignity into it. But in general, I think aging in place, as you mentioned, is what people really want. And then what we need to do, bring everything and hug them with whatever it is. And this is something that I hope, if I have provided any insight for you people, you know, I would appreciate that you take it farther up.
I promise you, we are collecting this and your words will be included in the summary notes that go out to everybody who attended this meeting and everybody who's interested in that.
No, I didn't leave it.
So we will incorporate your feedback. I don't know if you can hear me any longer. I promise you it will be included in the summary notes here. I do want to say Cheryl Brown had her hand raised and Janie Whiteford had her hand raised. So I want to ask you guys to give us some feedback, and then I'm going to have Lydia wrap us up. So Cheryl, go ahead, and then Janie, and then if you wouldn't mind Lydia wrapping us up, that would be fantastic.
I think my comment I wrote in the chat, and I almost don't remember what it was. It was so long ago. But I think this is a very rich conversation. I think that the conversation should, at some point, we should have Kim hear this conversation, or you need to send it to her since you're recording it. I also think that when we started talking about this, this benefit in the master plan on for aging, we started talking about it as a benefit that if a person doesn't have long-term care insurance, that they might be able to buy into a state program. And it seems that it's gotten a long ways away from that. And we weren't talking about cutting out anything that's already there. We were just talking about helping so that it's California for all. We were talking about everyone being able to be included, and they could buy into it if they didn't meet that income threshold.
Yeah.
So that's what it was all about.
And I think we still need to have that. I don't think that concept or conversation should go away by any means. And thank you. For those of you who don't know, that's our Assembly member, former Assembly member Cheryl Brown, who was the chair of Aging and Long-Term Care Committee in the Assembly. And finally, Janie, are you around and able to? Hi.
Hi. Yes, thank you very much for this conversation, and hi to all those that I haven't seen in a long time. My question, and really segues back out of what was just said, I'm wondering if, first of all, I'd like to know where the background on this thing is, because it seems like the Long-Term Services and Support Subcommittee wasn't even looked at, and their recommendations were not even taken into consideration when this came about, which brings me back to what Lydia was saying. Looks like it's a very political thing. And if we're going to be fighting this and questioning it, we really need to know where it came from so that we have a basis for our, you have to know from whence it came before you can really fight something. So if Lydia has an instinct on this, I'd really like to hear about it. Sorry, Lydia, putting you on the spot.
Well, you'll get to hear Lydia's comments right now. So I know that we've lost some people, but we have been recording it, and we will eventually post it, and we'll get notes out. Tanya at Choice and Aging has been furiously taking notes while this is going on, because we want to capture and collect everything that we're getting in terms of feedback and knowledge around this. But so thank you to those of you who have stayed on 21 minutes longer than we had anticipated, and for the next few minutes while Lydia, our fearless leader, walks us through sort of summarizing what we have gone over today and sort of what our next step should be. So take her away, Lydia.
Well, this has been a rich conversation. I don't want it to be over. I've been taking some notes. I wrote down a lot of the questions, but I'll try to just highlight a few things that maybe are good high-level summary comments. I think I'm going to start with listen to seniors and ask them what they want. I mean, how more simple can we get than that? And people with disabilities, for heaven's sake, seniors and people with disabilities, listen and ask them what they want. And then we can make that happen together. We have talked about needing a really robust stakeholder process, and particularly in asking for what the problem is and for whom we're trying to solve that problem, which has not been well defined yet. I heard a number of questions and comments on slow down and better define the program and how it is going to be cost neutral. A lot of questions and concerns rose around that, including Bonnie's remarks relative to what her decades of experience with long-term care insurance is. I think we have some strong lessons to learn from that. Building on what we have, I heard that loud and clear. That seems to be one of the top 3 messages. A stronger role for the legislature. I think Sarah mentioned that there's very little role for them other than approving the new licensure category, the way that the benefit is defined right now, or the concept is defined right now. A number of comments and good questions about how this benefit interacts with Medicare, waivers, and other services and programs. Another comment that many people made, read the LTSS subcommittee report and implement it. Read the damn report. So those were some of kind of the high level themes that I got out of the questions and comments today. As I said, very rich conversation. So honestly, I think everyone is fully capable of writing their thoughts down and submitting them to the Department of Health's website. If somebody can pop that address in there, I don't have it right in front of me. As I'm talking, I can't multitask. Maybe Renee, you can find that, or
she's already on it. She's already on it.
I figured she would be. I think some of those themes that we've talked about today really need to be put front and center in the comments, along with any other thoughts that you have, particularly your own experiences. Any of you who can share personal experiences on barriers and challenges that you have experienced, particularly in care transitions, would I think be extremely useful. So those are some of my top level thoughts and recommendations. Get those comments in, talk to policymakers. We only have through, well, we have recess now for the legislature. We only have through the end of August, and then the legislature goes on recess. So they would have absolutely no ability to influence anything after August. So there's a lot of work to do between now and then to either help shape this thing or to slow it down. Thank you.
Thank you, Lydia. And
welcome,
thank you to Sarah and Amber and Nancy and Lydia, all for presenting and for your brains and your minds and your hearts, and to all of you who took an hour and a half out of your afternoon to really look at this confusing proposal and dissect it and come away with some messages that we can together voice loudly as we move forward. So thank you for your partnership, and I wish you all a safe holiday weekend. Take care,
Thanks,
everybody.
Deb.
All right.
Thank you, Debbie. Bye.
Bye.